Welcome to our bi-weekly, webinar series for the Eye and Ear Foundation, Sight and Sound Bites. The Eye and Ear Foundation of Pittsburgh supports the two world-class departments of otolaryngology and ophthalmology at the University of Pittsburgh School of Medicine. We help affect how you see, hear, and live. Before I introduce today's webinar speaker, and I'm very excited about this topic, a few housekeeping tips. We are going to mute everybody. If you have a question, put it in the Q&A. Please refrain from personal medical questions. If those come over, we will answer them separately. And now I am excited to introduce Dr. Eric Wang. Dr. Wang is the Vice Chair of Otolaryngology. He is a skull-based surgeon and also a sinus specialist. He is board certified and he is just about the best there is. I'll let him talk about his research a bit more, but Dr. Wang, welcome and thank you so much for doing this today.
Heather, thanks again for having me. And it's always a great opportunity to get to speak to patients directly or people who are just curious about this, sometimes a little bit of an enigma title of, chronic sinuses. And it's probably one of the most common complaints that I see in my practice in my world. And even though we kind of call it one thing, it actually probably is, what I hope to show you, actually a variety of different pathologies that sort of run into the same idea and topic. So we're going to talk about the causes, at least to our current knowledge here in 2025, of the sources of chronic rhinosinusitis and try to give a little insight into how this is parlaying out to how we treat people and how we are now being more effective in the management of this kind of chronic inflammatory situation. So I always like to start with this Venn diagram because symptoms for sinusitis are not very specific. And we would love for them to be much more specific than they are, but they have a lot of overlap with a lot of other conditions. And so one of the most important aspects is for us to try to clarify this diagnosis. And as you can see here, some of these things are things we manage commonly in the ENT world and space, like allergies of the nose or deviated nasal septums. Some of them cross over with our dental colleagues. Some of them cross over with our neurology colleagues. And we use this term migraine to actually mean a variety of facial pressures, and I'm going to talk about that a little bit more. So I always think that we do need to sort of clarify some of these great mimickers of sinusitis. And what I mean by that are these conditions that have a lot of overlap, and it would be very difficult for sometimes even physicians, but also specifically patients as they begin to experience these kind of chronic symptoms to differentiate between them. So the first great mimicker, unfortunately, is headaches or facial pain. And it's really interesting. One of the funny historical stories is that people really didn't think about sinus headaches very much until a medication called pseudoephedrine came into the market. It's a nasal spray that some of you may know as Afrin or Four-Way or Clearway, and it's sold over the counter. It probably would not be sold over the counter anymore in our modern FDA. But back in the day when it came to market, they said it was safe to be over the counter. And that was when they made these classic pictures of red spots over people's sinuses. And in some ways, my friends in marketing tell me it's one of the greatest marketing campaigns ever because it took something that wasn't common and it made everyone believe that it was from their sinuses. But headache patterns can be very confusing because logically, we think, well, our sinuses are in these spots, and so if I have pain over them, it must be the sinus. But unfortunately, that isn't true. There actually are a variety of different other conditions and patterns of facial pressure which can mimic this. And I like to help people differentiate this because migraines, unfortunately, are a really great mimicker. So some of them can actually cause our nose and our brain nerves to tell our nose to discharge more mucus. So we think we have increased nasal drainage because of it. And in doing so, it also sometimes causes the nasal line to swell a little bit. So you can see that now some of these symptoms overlap a lot with chronic rhinosinusitis, where this pressure and pain in a region is associated with some increased drainage and some increased nasal congestion. And so it's sometimes difficult to differentiate among these various patterns. But when pain is the predominant symptom, they can oftentimes have clear CAT scans to show that the sinuses themselves have no inflammation or cause of it. And one of the problems can be this interesting thing that's now been described as midface segmental pain. So it's kind of pain in this central region. It's talked about a little bit more in Asia and Europe than it is in the United States, but I think that even though the prevalence is not very high, it's something we should pay attention to. So it's really, again, a clean CAT scan, which is our gold standard test for looking for sinus inflammation in patients who have pressure in this mid region through their nose and underneath their eyes. And you can see in like other countries that have big nationalized healthcare that it's not very common, but the big risk factors are people who have rhinitis, which is swelling in the nose, not so much the sinuses, and who are undergoing a fair amount of stress in their life. So it's an interesting phenomena that we see, especially in our developed countries where we are under a lot of pressure to deliver in a variety of different avenues and workspaces. Now, let's talk about a little about how often does facial pain correlate with the CAT scan? Because I've talked to you about a couple conditions where the CAT scan is clear. And so this was a really nice study led by one of my good friends in Utah. And what he was looking for was he was trying to understand the correlation between where people describe their facial pain and pressure and how often you found something on their CT as their gold standard test. And even though it seems, again, that logic of if it hurts here, this should be where the sinus issue is, the reality is there's actually very little correlation. And when they rate pain on these scales, these sort of sliding scales, the severity of the pain doesn't necessarily correlate with the inflammatory findings in chronic rhinosinusitis, you know? And so if you take the bigger group of patients, so you take the ones with chronic rhinosinusitis and facial pain, and you took it with all people with facial pain, actually the correlation was pretty bad. So it suggests that even though the nerves are telling us that we're having discomfort in that region, that the pain isn't, unfortunately, a really good localizer. So it's not like in other parts of our body where if it hurts in your finger, the problem is in your finger. I guess maybe the density of the nerves in our face just lack that correlation with the ability for patients and physicians to use that symptom as the driving determinant. So there are people, of course, who have sinusitis and have facial pain. So it's about 16 to 20% of patients with CT evidence and symptoms evidence of chronic rhinosinusitis report this facial pain. Here's the unfortunate thing. 40% of those people, even though their sinusitis seems to resolve on other kinds of tests, still have that pain. So if you take 20 as the highest number, and now you take it, and only a little bit over half of those people will have improvement, that means that we still probably have 10% of the people who still have facial pain and pressure despite their sinusitis and the rest of their sinus symptoms getting better, you know? And in that group that does get better, that 60% that gets better, all of them have a positive CAT scan. So I think that this really shows that the importance of having these CAT scans to really help us when we try to manage people who have, unfortunately, challenging facial pain syndromes. Now, another big cause of this, another big mimicker, so we're going to shift from facial pain, is actually things that are in the dental world. So we all know that our tooth roots go up into our midface and into that same area where we can often have pain or discomfort. And so dental pain is probably one of the most common mimickers of chronic rhinosinusitis. For any of you who've had to suffer from this, you know that it can last for a long time. And the two are not entirely separate. There are conditions where the tooth is infected or causing pain, and it also causes sinusitis. And there are other conditions where the dental or nerve pain itself is still present, but there's no sinusitis. So you can imagine the difficulty in distinguishing between those. Another great mimicker that we see very commonly in America, because in America, orthodontics is a very, very common intervention for most Americans, is that you can get pain in these jaw joints called your TMJ joints. And that can actually spread to the muscles that give us our chewing ability, which extend up into our temples, and then also kind of behind our sinuses. And so people will often describe that sort of mid-facial pressure and pain, although this tends to be more one-sided than two-sided. Okay. The last great mimicker is actually within the nose itself. So inflammation in the nasal cavity and inflammation in the sinuses, initially we treat very similarly. It can have very, very similar symptoms. In fact, the overlap is tremendous. They all get some difficulty breathing out of the nose. You can have increased nasal drainage, that same pressure, as well as a decrease sometimes in people's ability to smell things. And they can lead to two very, very different conditions, where one can be full sinusitis, like pictured above here, where the black spaces of air on the sinuses are now completely filled with gray inflammatory tissue. And the same patient can have, or sorry, the same symptom group in a different patient can have completely black, clear sinuses, like you see here on the CAT scan. And all of their inflammatory problems are within their nasal cavity. So you see now the importance of separating these, because we're going to treat each of these conditions in a different way after we get the initial therapeutics done. Going back to facial pain, one last thing about it. So when we start looking at sinusitis, we often look for those four classic symptoms of nasal congestion, nasal drainage, decreased sense of smell, and facial pressure. And in patients who have most of those symptoms, they tend to have a higher incidence, 50 to 60% of having chronic sinusitis. Not perfect, but higher. If you were to eliminate that facial pressure or facial pain group, you actually find a higher number of patients who have a positive CAT scan. So it calls into question about how important is it, should we be asking about this? Certainly patients come to see us for it all the time, but the etiology of that facial pain actually coming from your sinuses is unfortunately a little bit less common than we would like it to. I have to admit, when I do find sinusitis, I kind of like it, because a lot of times I do actually help the patient. And it's much more difficult when we can't. A lot of the other things involve other therapies through neurology or the dental world, which can be difficult, and additional challenges. The last great mimicker I sort of want to point out is acute sinusitis. So this is where, as Americans, we average about 2 to 3 viral infections a year. And in patients with recurrent acute sinusitis, which is an actual infectious etiology, it often starts with a viral sort of symptom, which you see here picked out in the green, okay? And most people should kind of go back to normal somewhere around 7 to 10 days. But in other people, every time they get a viral infection, they start to get better around 7 to 10 days, excuse me, about 7 days, but then by the 10th day, they actually get worse. So this is called a double worsening sign, where you're worse, you get a little better, then you get a lot worse. And that is a sign and symptom of recurrent acute sinusitis. Now, this is a little bit different condition, because this is actually, we believe, to be that the virus causes our sinuses to get swollen, and that little bit of swelling now closes off the sinus and allows a secondary bacterial infection to occur. This responds really, really well to antibiotics, and it tends to be completely normal in between episodes. So you are basically, I'm totally fine until I get a viral illness and I get this double worsening sign. And this is different than chronic rhinosinusitis, which is a condition that lasts a very long time, typically at least 3 months. So what is sinusitis? I always like to use this picture. It's an old picture now, but the nasal cavity here is outlined in yellow, and the sinuses are these pink structures exteriorly. So they're outside of the nasal cavity, but they influence and impact it. And oh, again, as I mentioned, the symptoms overlap a lot, but what we're really interested in understanding is that when we start getting into this diagnosis of chronic sinusitis, that it really is inflammation in these outside places, not just in the nasal cavity itself. It's defined very quite clearly at this point. It needs to last greater than 3 months. And again, it has those 4 symptoms that we talked about of increased nasal drainage, decreased nasal breathing, a decreased sense of smell, and then that pressure. But the symptoms, as I think I pointed out to you very clearly at this point, aren't enough. That isn't the definition. You have to have some objective findings because the symptoms overlap way too much without the objective findings. So you either need to see inflammation within the sinuses that you see here with a telescope that we often do in the office, or you get a CAT scan, which shows inflammation out into the sinuses themselves, which can also roll into the nasal cavity. Now, one of the things that has really made a tremendous amount of progress over the last 25 years is our understanding of what chronic sinusitis is. So even as when I was a very junior resident, there was still this belief that maybe chronic rhinosinusitis was an infection that just never went away. It just kind of smoldered along and continued along, and it's just an infection that we couldn't get rid of. But what we've really learned over these last 20 years is that chronic rhinosinusitis is not an infection. It is really an inflammatory process that mimics an infection. So here's the same symptoms, they last, right? But the key here is that you can have 2 kind of groups, one without polyps and one with. And they both are chronic rhinosinusitis. They're both driven by inflammation, but they tend to have slightly different symptomatology. So those without polyps, they do have nasal congestion, but they're oftentimes still able to breathe to some degree out of their nose. They tend to have a lot of drainage, and they had to have a little bit higher degrees of facial pressure. And this is what it looks like. The endoscopy, looking in the nose, actually doesn't show a lot because the sinuses are sort of hidden unless you've had surgery, but the CAT scan shows lots of inflammation within this, okay? In contrast, when you have polyps, you really get a lot of difficulty breathing, and some people are completely obstructed, where they get no airflow from one side or the other. Their sense of smell tends to be tremendously decreased, while having actually very, very little facial pressure. So this is how that looks, and this is easier to diagnose. So here is a picture in the office of a left nostril, and you see these little bubbly things, and it's this inflammation that is of the sinus lining, which is now swollen to the degree that you get these polyps that fill up the nasal cavity, and the CAT scan looks like this, and you can see no airspace in them very frequently. Okay, so looking into the office, you can also have concurrent problems with breathing from your nasal septum. So it is important that your endoscopy is very accurate so you can actually get all of the potential etiologies that are contributing at the same time, because it can be sometimes more than one thing. But here's a very good demonstration of a classic type 2 polyp. Okay, so let's dive into the actual meat of the talk now, which is what causes this chronic inflammatory condition in our sinuses that now gives us all of these terrible symptoms. Well, I mentioned that sometimes dental issues can be a mimicker, but sometimes the teeth themselves, odontogenic means teeth, actually can cause chronic rhinosinusitis. So why is that? Well, I think these pictures kind of show it pretty well. So you can kind of recognize the outline of a tooth here. And this black space above it is the cheek or maxillary sinus. And tooth roots can actually be up into the sinus. And where do we get teeth infections? Well, here at the root. That's why we have things like called a root canal, which is demonstrated here in picture A. This is where they made the canal into the tooth to allow the infection to drain through the canal. And so it happens at this root. And as you can imagine, if you have a bad infection in this space, now this can now begin to infect the adjacent sinus. So the sinus itself has no inflammation, but the tooth can then drive inflammation in the sinus, and in this particular case, actually an infectious problem. Now, this is different from something called a mucus retention cyst. So this sometimes happens in people who have bad teeth, but sometimes it just happens and we don't know why. And in fact, if we were to scan 15% of the people who feel totally normal from their teeth, um, if you scanned 100 people with totally normal no nasal symptoms at all, you'd find about 15 mucus retention cysts. So they're pretty common. They tend to start on the bottom of the cheek sinus. And this in and of itself isn't really a problem. This is just a cyst that's there. We almost never do anything about them. And it's just, again, another one of those findings that you sometimes see on scans or x-rays, or a lot of times your dental x-rays is a common source of these. But when you get a real CAT scan that allows you to look at all the rest of the sinuses, this is not a problem and doesn't need any intervention. Now, there are situations, though, where those tooth roots being in the maxillary sinus can cause real problems. So here, this is actually a bad tooth. I know it's a little bit difficult to differentiate, but you can see there's a little bit of a crack in the tooth. There's some swelling around the tooth root, which is seen here. And then you compare this patient's right side versus the left side, and you see this increased gray swelling in the sinus. And here in a slightly different view, you sort of see the same sort of pattern. Well, does this patient absolutely need sinus surgery? Actually, no, this person doesn't. What this person needs is their tooth to be taken care of, because most of the sinus, including this drainage pathway, which I've outlined here in yellow for us, it's swollen, but it's still open. And when it's open in this particular setting, actually, as long as the tooth gets corrected, sometimes unfortunately it means removal of the whole tooth, but sometimes endodontists can do root canals to salvage the tooth, then actually the sinus will get better on its own. And it won't need anything else, because the inflammation, once you no longer have the tooth nidus, will then resolve. But there are other situations where the sinusitis lasts longer. So here's the bad tooth. You can see the gray in the cheek sinus here, and versus the black on this other side. And in this particular situation, what has happened is that the infection has now spread outside the cheek sinus and gone up. So now, instead of just being in the cheek sinus, it spreads to the ethmoid sinuses near the eye, and then finally to the frontal sinuses in the forehead. And when it's spread outside of the cheek sinus, unfortunately, the vast majority of the time, sinus surgery is required to clear this chronic inflammation and infection before you can have complete resolution of symptoms. Classically, in this setting, people tend to get a little bit better with antibiotics, their drainage and their pressure goes away, but then it just comes right back within 3 to 4 weeks. And that's a very classic pattern that you see in this odontogenic sinusitis. But these people tend to have a lot of really, really foul smelling drainage. Not just like, oh, I have a lot of drainage that kind of bothers me, but actually kind of smells bad, just like, a bad rotten tooth might kind of smell, okay? And sometimes they have a lot of pressure, other times not. But what's really interesting is actually when you ask people, they almost never have pain at the tooth itself. And it took me a little while actually to figure out why that is. And it's because actually the reason we get dental pain is that when you have an infection, it causes that swelling right next to the root, which actually erodes the bone near it. Okay, so if that happens in your lower jaw, it hurts because the bone is being pushed and eroded. But the sinus is different because there's not that much bone there. So the erosion happens pretty quickly. But once that has passed that point, now you have a really, really big space for it to be filled with pus and infection. And so actually people really rarely have dental pain, which is kind of not what we would expect, but it makes sense when you understand what the drivers of dental pain are. Okay. Additionally, there can also be sinusitis from dental tumors. And this is a tooth I took out in a patient who got pushed in during some sort of procedure. Sometimes you can also, it's really common nowadays to get dental implants for dental restoration. And sometimes if these were to get infected, the foreign body can cause an infection and chronic rhinosinusitis in this particular condition, which is pictured here with this implant being placed into the cheek sinus. So the treatment, as I mentioned, is sinus surgery followed by antibiotics, and it's so much more effective once the sinus surgery, essentially, as I tell people, it kind of lances the boil. So if you have an abscess on your hand, antibiotics get it better around the periphery, but the antibiotics can't get into the center. Just like the sinus, there's no blood supply into the center, and antibiotics are carried by the blood. So we have to drain that area, i.e. lance the boil, and now the antibiotics are much, much more effective. And this is one of those conditions where I treat a lot of really, really happy people because we get rid of their foul drainage, we get rid of their facial pressure, and in truth, they probably forget about who I am in about 2 or 3 months, and that's a good thing. You don't know, I don't have to always remember things forever. Okay. So this is a really beautiful paper done by one of my colleagues at Henry Ford, which is in the Detroit area, where it talks about how together ENT doctors or otolaryngologists, as well as a variety of dental providers, I find endodontists to be really, really helpful people, can work together to help both confirm the sinusitis portion of it, as well as the odontogenic portion to confirm this etiology. Okay, and here are some of the signs and symptoms we're able to do. But again, that idea of a really foul smell, and then sometimes you find the right bacteria from the mouth in the sinus culture itself, and that the two can often work together to give people the very, very best outcomes. And I would say we're very fortunate in the Pittsburgh area to have some really wonderful dentists to allow us to work in this sort of collaborative manner. All right, so that's one unique subtype. But to be truthful, that's still an infection, and it's an infection from a different place. But do we get a lot of infections in the sinuses themselves? And this is where it gets a little bit trickier. So we talked about polyps, and what we know now is that in polyp patients, they really have a high increase in these things. IL stands for the word interleukin. But basically what they are, they're signaling molecules, how our body communicates through each other that increase inflammation in this particular disease. And these inflammatory drivers cause the lining to swell and eventually form the polyposis, as well as cause this thing called tissue eosinophilia. Eosinophils are, in some ways, very like allergic kind of inflammation. All right? So, in the normal setting, we have these interleukins or cytokines that have inflammation, and then we have the regulatory cytokines, and they live in a balance where there are times when our nose needs to get inflamed. That's obvious for things like fighting viruses, but even just to clean your nose from as it's filtering through all the bad air all day long, those inflammatory cytokines go up. And then the regulatory cytokines then turn on 2 to 3 hours later, and that allows you to breathe through your nose. And they kind of go back and forth from side to side. But in chronic rhinosinusitis, we get a whole lot more inflammatory cytokines and actually very, very few, relatively few regulatory cytokines. And it's this dysregulation that gives us the sensation that we're having an infection all the time. Because when we fight viruses, we have this same sort of structure where we need more of those inflammatory cytokines to get rid of the infection. But then we're supposed to go back into balance. And that's why it's been so confusing for so long about what was the drivers of it. So we can pretty safely say now it's not infections or chronic infections, but these inflammatory imbalances that have driven most of the symptomatology that we're experiencing. So that's great and all, but why does it happen in the first place? Why does this not kick in most frequently into our 40s and 50s? And we're just starting to unpack some of that. And one of the areas I think has been really exciting over the last 5 to 7 years has been looking at the effect of air pollution and how it impacts us and maybe in our sinuses. So what is air pollution? Well, it's a lot of different definitions. One of the most common things that people use is they describe particulate matter. So things that are in the air, and they tend to do it by size rather than by what the specific things are, okay? And so this was a really big study out of the UK. It's actually co-authored by one of my good friends at Hopkins, who they use the national health system there because it's a big kingdom or UK-wide biobank. Okay, and so they're able to follow people for a really long time. And as you may or may not know, the UK has quite a long history of coal burning, which is not so different from our Pittsburgh area. And so it was a really interesting population to study. And so they followed this very large cohort of almost 370,000 people. And then they identified this relatively, I think, still what seems like a low incidence of chronic rhinosinusitis, which you see here is 1833. So even though we think sinuses are a big problem, and they are in many ways, if you use this incidence, it's actually not that many people develop them. But if you now go back and you correlate where they live with their incidence of developing sinusitis, this chronic inflammatory pattern, it suggests that air pollution, like increased air pollution, is correlated, not maybe causative yet. We can't really say causative, but we can say that the two tend to go hand in hand. So the more air pollution in the area, the higher incidence or how often chronic rhinosinusitis occurs. And then when they started to dive into it, actually, not only is it more prevalent or more common in those areas, the symptoms tend to be worse, okay? And so hazard ratios basically are ways to describe how much increased risk are you. And these are two terms I'm going to use a lot, PM 2.5 and PM 10. They stand for particulate matter 2.5 microns and particulate matter 10 microns. So again, we measure by size. And if you look at how much increased risk, it's about 60% if these things are increased at a certain level in the population. So that's something, It's still not high. It's not that every person who's exposed to air pollution gets chronic rhinosinusitis. In fact, actually, still a very small minority do. But it's interesting that the two are correlative, maybe in people who are somewhat predisposed. So let's talk a little bit more about PM 2.5. So this is courtesy of Murray Ramanathan, who is really one of the experts in this area. He's the vice chair of Hopkins, so he has the same role at Hopkins that I have here at University of Pittsburgh, and we sort of have grown up together and have shared a lot of research interests together. So this is a slide from him where it kind of shows the relative size of PM 2.5 in comparison to PM 10, and you see how tiny they are. It's a really, really small size, and you think of something small like beach sand. This is infinitely smaller than that, as you can kind of tell by this diagrammatic picture. And then this is supposed to picture a hair on your head. And so actually, it's a bunch of different things. It's a lot of things from our industrial world, from cars. It has organic compounds, and even, shockingly, a small amount of very, very fine metal present within this. So this is a really interesting idea because here is some of the things that we know about PM air pollution and these small particulate matters and how they interact with our nasal lining and our lung lining. So in these small particulates, sometimes what they can actually do is they can actually sort of disrupt the barrier or the wall function of our nasal lining. And when they do disrupt this sort of lining, it now elicits an inflammatory response. And this gets kind of complicated moving down. But some of these same markers, interleukin 4, interleukin 13, now get increased because of this epithelial disruption, which we are beginning to understand more and more can happen from things that we just experience in our environment every single day. And as they open up this may be a pathway to begin some of the inflammatory things that we start to see in our nose, in our lungs. And the correlation for asthma is even much higher than the chronic rhinosinusitis. But we're learning more and more about this and this potential role for us. So this is a study now looking at California. And so in the Bay Area, if you look at where you live, and how often you seek a visit for sinusitis. If you live in an area that has a higher particulate matter 2.5, you actually have a lot more office visits than in people who have a higher levels of particulate matter 10. So it seems like these smaller particles tend to have even a greater negative effect on people than particulate matter, at least as far as seeking care. And this is what this study sort of concluded. So lastly, can we get better information about maybe more than just population correlates, but can we actually now correlate it with maybe those same interleukins or cytokines, those signaling molecules that drive inflammation? Can we understand how that may happen? And so this was a really, really beautiful study done out of the Nashville group, where they correlated the PM 2.5 exposure in their sinus patients. So they gave everyone a relative amount of risk. And then when they did their sinus surgery, so that is one downside of this particular study, is that it was all done in patients who had sinus surgery, okay? They now started to look for, with a swab, which interleukins are present. So which of these are increased or driven by it. And again, that same 2.5 thing, that particulate matter 2.5, drives particularly IL-13, which is one of the most common increased inflammatory cytokines. So the more particulate matter a patient may have experienced by their zip code, that they have more tissue swelling, more of these signaling molecules happening is increased with this exposure. And this is that same sort of ratio that shows that it bothers people, or excuse me, it influences not only the sinuses, but also the lungs and to some degree the nasal cavity in a similar sort of way. Okay. So can we get down even beyond like these swabs, like what interleukins are sort of showing? And so this comes out of the Chicago groups, and now they're really looking at what do you find on the pathology in this particular situation. This group is very fortunate to have a pathologist who's actually really interested in sinonasal inflammation. And so what she did was she looked at kind of blinded, sort of rated the amount of inflammation. And basically, in short, in zip codes in the Chicagoland area that had increased overall air pollution, and they didn't really classify exactly what that air pollution was. So I can't tell you if it's certain kinds of particulate matter, but just air indexes like you get on your iPhone. Those who have lived in places that had higher indexes or worse air quality tend to have more inflammation, and especially that same eosinophilic, same words, type 2 inflammation, including these classic Charcot-Leyden crystals, which are just a marker of eosinophils, okay? So here you can see that there are some demographic things, so correlate between population and incidence. There are some direct quantitation of what those interleukins are driving in addition to the population and in the pathology itself. So I think this gives us some compelling evidence that at least it may not be the starting point, but it can certainly exacerbate symptomatology. And who knows, maybe in time we'll understand more and more about this, that it really is a driver for our own situation. Now, bringing this back home to us here in Western Pennsylvania, and for those of you who are logging in from other places, please forgive a little home cooking here. But we did the same sort of study, and our air quality in our area has certainly improved tremendously over these past 30 years. But we're not perfect yet, and in fact, actually by most metrics, we still have a little bit higher degrees of air pollution than a lot of areas. But what we did was we looked at our population of sinus patients, and we sort of looked and try to like classify them out again by zip code, which is not perfect, to sort of look at their particulate matter and their black carbon indexes, which is kind of the classic thing that you look for from automobile exhausts and from coal refineries, of which we're quite famous for here in the Steel City, and then nitrogen dioxide levels. And we weren't really able to, at least in our population cohort, find such a clear driver of particulate matter and these air pollution indexes and the sinusitis. But one of our challenges is that our area is a little bit homogeneous and that none of our areas are tremendously worse except in the PM 2.5. And we didn't have enough to show the difference there. But what we did show was that unfortunately areas with lower socioeconomic status tended to have more increased exposure to the air pollution, and they tended to have more severe sinusitis. Severe by the number of medications they had to take to get their sinusitis under control. So this is our own internal data that has been published and peer reviewed. Okay, so another common thing that we all experience, and maybe this winter was one of the worst, was, what are the role of viruses? And so we did some early work on this, kind of looking to see if viruses cause chronic rhinosinusitis. And to be truthful, it was a little bit difficult because actually not that many people had positive viral screens when we put swabs in their nose. And that's one of the challenges of viruses is they're actually kind of difficult to correlate. But what we did find is in patients who did have positive viral screens, that their quality of life was worse. And now we all know what coronaviruses are. But back in 2015, actually, this was still relatively not a very common thing to talk about. But we were already talking about the effects of coronavirus on our sinuses and how that impacted our clinical presentation, making people feel worse. Now, the truth is there is a lot of controversy over whether viruses can induce sinusitis. And unfortunately, I don't have a clean area argument for you. But we do know that in general, what ends up happening is you get a viral infection, and now these interferons or interleukins now start to respond, okay? And that causes some loss of that barrier again, like we had mentioned. But that in most situations, our body heals. Now it's 7 to 10 days, and we go back to normal epithelium. The hypothesis, again, not proven, of how a virus might lead off into a chronic rhinosinusitis is rather than that, that viral load and that interferon peaking and then shrinking, it actually stays higher for a longer amount of time. And that now drives that type 2 inflammation, and the same barrier loss no longer can heal. And then we have a chronic inflammatory state. So this is the idea or the concept, although in truth, still very much in the concept sort of realm. So it can function across all of these different pathways, and I'm not going to get into too much of the details of this, but the key ones are the cytokine and inflammatory response, as well as that epithelial dysregulation. And so that same barrier function that particulate matter might influence, also viruses may have a very similar sort of negative effect. But the reality is we don't really know. And that's still an active area of thought, but actually a very, very difficult area to study because we rarely see people in those early stages. Now, fungus in chronic rhinosinusitis was a really popular thing in the early 2000s, and it still has some role. So one of the classic things that can cause symptoms of sinusitis is this thing called a fungal ball. Now, the reality is that all of us live with fungus in our nose. It's ubiquitous. Every single person has it. But in some people, they'll get a population that start to proliferate and grow. And it's not an infection in that it doesn't ever invade the sinus, but it tends to fill up the whole airspace. And so now the sinus can't function normally, it can't clear all of the things and all the mucus that it's supposed to do so. So the treatment for this is removal of that fungal ball. And more often than not, once you get out that fungal ball, then most people actually never have symptoms ever again. And so this one's a pretty straightforward and easy one. But there's another condition called allergic fungal sinusitis, which we really have a much, much more difficult time dealing with. So this is a classic nasal polyposis sinusitis with, again, that same type 2 inflammation and eosinophilia that we've been talking about over and over again. In fact, it's characterized by this thick eosinophilic mucin. A lot of times patients will even tell you they blow this out. It's like like raw honey, sort of in its constituency. It's very, very sticky. And it's a long time question as to why people have this. Now, the truth is we have less of this in our Northeast, but in the Southeast of the United States and all the way to Texas, it's incredibly prevalent. There are also certain areas of the world, the Middle East is another hotbed where you have a lot of this particular inflammatory process. So this is the criteria for which people have traditionally classified this. And we sort of moved on from some of them. But what we never really could understand is if all of us experience fungus in our nose, why does this drive this problem for us? You know? And the truth is we're still learning more and more about it. And well, the first thing we know is in chronic rhinosinusitis with allergic fungal sinusitis is that these three inflammatory drivers are really strongly upregulated, okay? And that's been shown actually in a lot of different studies now, and it's been pretty widely accepted. But we don't have a really good reason as to why. Why did fungus drive these three inflammatory markers? And so now one of our colleagues, actually last year, our Ferguson lectureship for chronic rhinosinusitis was Amber Luong, and she is the expert in this particular area of histamines. And so these are some innate immune responses that we're supposed to have. So histamine is supposed to help us get rid of fungal material when they get into the wrong places. And so the hypothesis here is that we're actually missing this histamine, or it's decreased, and it gives us a relatively decreased focal immune response. And so with this decreased focal immune response, we no longer can clear the fungus that we sort of breathe into our nose every single day. And then now they can become these fungal hyphae, which are pictured here on a scanning electron microscope. And that it's this, these fungal spores and this inability to clear that now drive that epithelial barrier to open again. And so that leads to that inflammation. And it similarly causes a similar symptom in asthma, which is, again, sort of this cousin to chronic rhinosinusitis. So one of the drugs that you may be aware of called dupilumab is one of our newest monoclonal antibodies. So an antibody is something that blocks a specific response, and it works right here at this IL-4, IL-13 junction. And this is how dupilumab can help people with this histamine dysfunction, and it can actually stop the inflammation at this particular level here. The last subarea of chronic rhinosinusitis I want to talk about is aspirin-exacerbated respiratory disease. This is a disease that tends to pop up a little bit later in people's lives, but earlier than regular chronic rhinosinusitis. This happens typically in the third and fourth decade. And one of the classic things to ask is, do you get worse nasal symptoms when you drink red wine? And this population, for better or for worse, they can tell you that they really have a lot of nasal symptoms if they drink the tannins in red wine. And it usually starts with nasal drainage. The next symptom that develops tends to be asthma. And then finally, the chronic rhinosinusitis and the lack of ability to tolerate NSAIDs, which are things like aspirin, ibuprofen, and drugs in that particular category. So we are still trying to understand this one, but we know that this one is an acquired, so you're not born with it, but it's an acquired metabolic condition where when this starts, when we take a aspirin or any sort of NSAID, this COX-1, COX-2, which is sort of the pathway that it works on, now gets upregulated, and then we derive all of these huge inflammatory conditions from this. And this is one of the most recalcitrant or difficult sinusitises to manage. Now, this one now, we've made so much progress in being able to accurately diagnose it. So the Mayo Clinic is still the only place in the United States that offers this particular testing. But if you wanted an absolute diagnosis of this, you can collect urine for 24 hours, and then you can look for this thing, leukotriene 4, where you look for a specific level of it, and it's increased predominantly in this aspirin-exacerbated respiratory disease. So this is an area where we can actually make a very clear diagnosis. And we have interventions that have been partial in their effect, working through some of these drugs here that block this pathway. But unfortunately, despite blocking these pathways, there's so much redundancy in the system that people still tend to have a lot of symptomatology from this. And so we're looking at new and novel ways to overcome this, and this continues to be an area of active investigation, again, for biologic therapy. Okay, so in my last 3 to 4 minutes here, I hope that I've given you a reasonable overview of where we stand in understanding what causes chronic rhinosinusitis. And I'd like to talk to you a little bit about what our research is at, because I think we have some exciting things going on in our group. So we have currently opened a trial on one of the other biologics that have an approval for chronic rhinosinusitis. It's called mepolizumab. This drug has a really outstanding history in now a 12 to 13-year history in asthma, and it blocks one of the interleukins, IL-5. And so we're excited to see what the real world life trial is in this. So basically our current enrolling trial is patients with polyps who failed standard of care therapy. And we are following them prospectively over an 18-month time frame with quality of life studies to see how well people respond with a combination of endoscopic grading, as well as side effect profiles, and then overall quality of life. So it's actually a pretty exciting trial to see, not in a controlled setting like we often do clinical trials, but a real life setting, how people are responding and how long and durable the effect is. The second area we're really focusing in is on drug delivery. So this is with Steve Little. Dr. Little is the chair of chemical engineering at the University of Pittsburgh. And we have been working to develop this thermoresponsive gel so that we can deliver disease-modifying drugs into the paranasal sinuses. It's incredibly clever in that at low temperatures, it actually is a liquid, but when it gets to body temperature, it becomes a gel. And so in that gel, we can embed small microspheres of drug. And the drugs can actually vary from standard things like steroids all the way to things that we think might help restore epithelial barrier, things that may help us reduce the overall inflammatory response, and even bring in and recruit cells that can help maybe tamp down that inflammatory imbalance. So we're still kind of in preclinical models, predominantly with rabbit models, but we think this is an exciting avenue of helping people without having to use daily application of medication. And then finally, our last area of study that we're really starting to dive into now, and really looking for some help as we move forward, is I alluded a little bit to these biologic or these monoclonal antibody therapies. And while they are really, really effective, they're unfortunately also really, really expensive. And so we really want to be able to identify, before just trying it out on somebody, can we predict through either their cytokines or more, what we're more interested in is looking at the single cell RNA or the expression of a cell in a polyp to understand, are there specific molecular correlates that determine if someone is going to be a responder or a non-responder to the therapy. And then even more so, who are those people who are going to respond, but over time actually have persistent symptomatology? And so we really are, we're working on our initial banking criteria for this, banking people who are candidates for their biologic therapy, and then their persistent symptomatology with subsequent high-level analytics to try to understand the back differences that may occur in a really pragmatic way, so that we can help people decide what is the right intervention for them, and help predict those people who will have a great response to therapy. I'd just like to point out my other really wonderful colleagues, Carl Snyderman and Gary Chobe, who are also in my division of rhinology. A lot of them contribute greatly to the work that we do. And with that, I'd be happy to take any questions. Thanks so much for coming. And it's just always an honor to be part of the foundation and the great work that they do for both us as physicians as well as our patients. So thanks so much.
Dr. Wang, thank you so much. We have a ton of questions. If we don't get to your question by the end of the session, we're going to get you an answer so that everyone will be answered eventually. So let's just jump in. So, is there any evidence that chronic sinusitis can cause the optic nerve to swell, which could lead to blindness? Very good question.
Yeah, so it's possible, but it's very, very, very uncommon.
Okay.
So the optic nerve is actually pretty well protected by bone, and that bone acts as a pretty robust barrier. So you have a epithelial lining, which can get broken down, as we talked about, but the bone doesn't tend to get broken down. If anything, what ends up happening is the bone actually gets a little bit thicker to
Okay.
try to protect us from it. So there's not a lot of evidence that sinusitis really directly causes blindness, except in a handful of very unusual situations. In my 14 years here, it's happened twice, and I think I take care of, and my team would take care of almost anyone in the city of Pittsburgh and the surrounding area where that would happen. So it's not impossible, but it's actually quite limited. Yeah.
Gotcha. And that's good.
Mhm.
Can rhinosinusitis cause a loss of taste?
Absolutely.
Absolutely. Yes.
Absolutely. So the way I sort of help people understand it is I call it the ice cream challenge. So our tongue is really good at giving us the big things: sweet, salty, bitter, things like that.
Mm-hmm.
Our finer discrimination actually happens oftentimes to some degree with our sense of smell. So it
Okay.
kind of goes up behind our palate and gets into a higher area.
Mm-hmm.
So if I give you a flavor of ice cream and you can tell me it's sweet, but you can't tell me really if it's vanilla, strawberry, or chocolate, you sort of lost some of that finer discrimination, right?
Right.
And so that's where the sense of smell impacts the sense of taste. And
Gotcha.
so the inflammation that can happen in chronic rhinosinusitis can absolutely cause that loss of refinement and manifest itself as a sense of decreased taste. Mhm.
Okay. Let's see what we have next. Do you have any insights? And if I pronounce these drugs wrong, please correct me.
Sure.
Rynair and Vivier? And do you
Sure.
have any proven durability?
So Rynair and Vivair are for rhinitis, not
Okay.
chronic rhinosinusitis. So they're for nasal cavity problems, and both of those tools use radio frequency to
Okay.
deliver energy to an area with the idea of causing it to have some scar underneath it, and that scar now opens up some spaces in the case of um, Ryanair and Five Air, and the other one you use to actually sort of injure some nerves that give you drainage into your nose. Okay,
So is this a drug or is it a medical?
it's a device.
It's a
It's a device.
device.
Yes,
Okay.
I'm sorry. Thank you, Heather, for clarifying. It's a device that delivers radio frequency, which is an
Okay.
energy source, and the goal is to cause scarring in either some nerves so that you have less input to make drainage,
Mm-hmm.
or to shrink down some areas so that maybe you can breathe a little bit better. Um, so for the one that is used for drainage, it seems like about 75 to 80% of people get some improvement if you use that for the right indications.
Mm-hmm.
The easiest way to predict it is someone who responds to this medication called ipratropium. So that's a drying agent. And so if you respond to that drying agent, you have about a 75% chance of responding to that particular medical device.
Okay.
Mhm.
Very interesting. So, we like this one. No question, just an observation. What an amazing talk. Thank you so much.
Oh, that's kind. Thank you.
How impactful is the use of a natural gas stove for indoor cooking? And is it worth switching to non-gas stove for people with sinus history or current symptoms, or even just prevention by limiting exposure to PM? That's very interesting.
That is a really wonderful question. So, natural gas does contain a very, very small amount of particulate matter in it. It's actually not the PM 2.5. So, theoretically, in the United States, our natural gas should not contain that particulate matter. A slightly larger particulate matter is present. But the reality is that if you were an all-day chef, and let's say you stood over a stove for 8 hours a day, it might make a difference. For the average American who cooks for 20 minutes, something like that, 30 minutes, I don't know, how long you're over your stove.
3 minutes. Yeah.
Microwaves don't count, Heather.
Okay.
So real stuff. Actually, the exposure is actually quite small.
Okay.
And in fact, probably slightly less than if you were driving an hour or so on the road.
Okay.
So I don't think there's a recommendation to really change it at present. The biggest recommendation is actually having an adequate fan. Like so,
Yeah.
that's really the key. Actually, is good ventilation and circulation. So it's a great question. It's totally worth thinking about. One of the biggest problems we have really is that we can't seem to, in an individual way, change our exposure to particulate matter. It's probably something we probably have to do more, kind of like in a societal way, just like we're
Mhm.
now so much more cognizant about microplastics, right? We're all
Right.
using a lot less plastics. So it needs to be a little bit more of a global sort of attempt rather
Mhm.
than something an individual could do. And so there's not really any sort of recommendations for it yet. And I would say it's probably unlikely to, just because the amount of time we spend is so little in that particular setting. But what I
Compared
always
to,
advise others is it's really important to try to get good ventilation, right? You would
right.
never want your outdoor grill in your house. That's not good, right? So we need that ventilation to sort of clear it, because it does definitely it reduces our exposures in that particular sector.
I hate this, but we're actually over time. If to anyone on this webinar, if you send us a question, we're going to get you answers and we're going to send them back to you. But I want to thank, first of all, the audience for being so interactive with this. I think this is the most amount of questions I've ever gotten as the moderator. So this is great. And I want to thank Dr. Eric Wang. Thank you so much for all that you do. And it's obviously a very popular topic.
Well, thanks again, Heather, and we'll do our best to get everything answered in a timely fashion. Okay.
That sounds good. Thank you, everyone.
Okay. Bye
Bye-bye.
now.